we'll get started now, if that's okay.
Hi, my name is Doris-Eva Bamiou, and I'm a doctor for hearing imbalance. Katie asked me to come over and talk to you about auditory processing disorders, and there is a very good reason why she's asked me to do that. I'm not sure this slide probably shows that doctors are not very clever at things, because I am very much aware of how hearing impaired people hear and what their hearing needs are, but I'm not very much aware of visually impaired people and what their visual needs are. So I apologize. My slides are always very busy, and let me talk you through them rather than trying to read everything that's there. But I like this. This I put as instead of an introduction. It's from an abstract of a scientific paper, and what it says really is that there is a mouse in a field, and the mouse is inside the grass, and suddenly the mouse hears a bird coming towards it. And the mouse thinks that the bird is going to eat him and starts going away. And taking this decision that is so important for the mouse survival is dependent on the mouse hearing and processing the hearing information and putting meaning to the hearing information. So the mouse gets the sound that the bird is making, analyzes the sound, gets where the bird is coming from and how long roughly it will take the bird to come there, and makes a conscious decision that this is a threat and that the mouse needs to go to save its life. And this is a good example of what we all do on a daily basis with our hearing. We get in sounds, and we have to analyze these sounds. We have to put meaning to these sounds, and then we make conscious decisions, and these decisions affect our life, our survival, our well-being, our relationships with others. So what I'm going to talk to you about today is I'll talk a little bit about auditory processing, and I'll tell you what we mean by the term auditory processing disorders, what the symptoms are, some risk factors, how we make a diagnosis, and how we manage patients with this diagnosis. And the last few slides will be about PAX6 and auditory processing. And the reason I'm here today is because we've done some studies on people with PAX6 mutations, and we found problems with their auditory processing.
I should just say, if anyone didn't know, PAX6 mutations is the most common genetic mutation that causes Aniridia. So basically, somebody who has Aniridia almost certainly has a PAX6 mutation. And that might mean that they may develop a multiple processing disorder as well.
Okay. So a little bit about hearing. And you all have an external ear, the pinna, and this shows you the canal and then the middle ear, and then after that there is the hearing nerve. So sound is collected with the ear, it goes through the ear canal, into the middle ear, and then into the cochlea, the inner ear, where it's analyzed. But further analysis takes place further up in the brain. So what this shows you is you get to hear, say, people talking, or a violin, or sound of water running. And all these sounds will be analyzed in the cochlea, in the inner ear. So the ear will analyze them in terms of what frequencies they have, in terms of when they come in time, in terms of where they come in space. But then all this information goes up to the brain, and there is a lot of very complicated analysis there. And this analysis helps us to detect a sound. Oops, there's a sound. Perceive, this is a conscious perception of the sound. Recognize, oh, it's speech. Oh, it's a baby crying. Oh, it's music. Attend to the sound. You all know that at this point there are some sounds behind you. Somebody's bringing in food. You don't attend to that. You attend to my voice, because hopefully I'm saying something interesting. Memory. You have to remember what I tell you in order to derive meaning. If you forget as we go along, it won't make sense. And learning. What you hear shapes how you respond to that. And a good example is, I've got a bit of an accent. Some of you may have found it a bit difficult to listen to my voice to start with. As I continue talking, you learn to adapt to my accent, and it's easier for you to get what I'm saying. So all these things happen in the brain. And I put a graph of the brain which says something to, doctors, but probably not much to non-doctors, just to say that it's a very complicated thing, and as the hearing information goes up, there is more and more nerves and brain cells that deal with this information to make meaning, to take meaning. And now we come to what we call auditory processing disorders. In previous years, patients would come to us, they would say, oh, I can't listen very well in noise. Oh, I can't tell where sound is coming from. Oh, music doesn't mean much to me. We would do an audiogram, which is the test where we get what's the softest sound you would hear. And if that was normal, we'd say, oh, you're mad, go away. Thankfully, things have progressed. And we've come to realize that nothing is as simple as that. Hearing is complex. We should be testing it with more complicated tests. So in the last few decades, we started realizing some patients may have listening difficulties, even though they can get soft sounds all right. And these listening difficulties may be because their brain doesn't analyze the sound very well. So we started talking about auditory processing disorders. And we think it's not rare. We think it's present in about 5% of the general population when they're school-aged, and even more in adults. And we started having professional conferences to decide how to deal with this. A very broad definition. Auditory processing refers to what we do with what we hear. So just keep this in mind. And when we're talking about an auditory processing disorder, APD, well, this is a professional kind of definition, but the second line says that it is characterized by poor perception of both speech and non-speech. It has an effect on everyday life because we don't listen very well and you don't respond appropriately to sounds. And it can occur with other developmental disorders like attention deficit disorder and so on. What are the main symptoms? Well, this study gave a questionnaire to parents of children who had listening difficulties. And these kids were found to have difficulties listening in quiet, listening if there is background noise, listening even if everything is ideal. You have a good visualization of somebody's face, there is good light, there is no sound other than the speaker's voice, there is no visual distraction. They had problems if multiple inputs were present. They had problems remembering what they heard. They had problems attending to what they heard. And then another study found similar things, and they also found problems with behavior, problems with music, problems with discrimination of speech sounds, okay, fat or cat needs you to discriminate well, and perception of loudness. So when we talk about auditory processing disorders, APD, the symptoms we see are difficulties getting speech if there is background noise or if there is reverberation. And this is a roughly quiet room, but acoustically it's not a very good room, particularly for those of you at the back, because it's a room with hard surfaces, so my voice echoes in the walls and there is a little bit of distortion. And an example of more distortion is when you're in the tube and there is a loudspeaker signal and you hear this echoing and you can't tell what it says. Problems with localization of sounds. You hear a sound, you should be able to tell where it's coming from without looking. If you have to rely on vision, then that might be a problem there. Difficulties hearing on the phone, particularly the mobile phone, which is more difficult than the landline. Difficulties giving appropriate responses to questions. Kids at school, the teacher asks something and they don't understand the question, they say something completely inappropriate. Difficulty following rapid speech. Kids or adults with these problems will frequently ask you to repeat. They'll say, huh? If they're older, they'll ask you to rephrase. If you give them instructions and they're long, they may have problems following these. They may have difficulties getting the tone of somebody's voice. Is this a joke? Is this a happy voice? Is it a question at the end of the sentence? And there are difficulties with foreign languages, with music, and at the end they may get academic difficulties, some difficulties with reading, spelling, and or learning problems. These symptoms, however, are not diagnostic of APD because you can have these problems with a great many other problems, say if your IQ is not too high, or if you're a foreign speaker of the language that you're trying to listen to, or if your problem is just in the language domain without being auditory processing. But if you've got APD, well, in kids, symptoms can present early in life, or people may start thinking about the child having problems when academic demands increase later on. Sometimes symptoms can happen all of new. It may be a new manifestation of a problem within the brain, while the adults tell us that they have always been like that since early life, or they tell us that, well, they started having these problems after they got, for example, a head injury, or things happened more progressively, like, for example, in the elderly population. And this, again, is a busy slide giving you some risk factors. So, neurological conditions, and I've highlighted there genetic PAX6. As Katie said, PAX6 is a mutation which affects your eyes. You've got congenital aniridia. It also affects your brain's structure. So you've got some parts there that do not function as well as they should. So this can be a risk factor for you to have this problem. But there can be additional problems, like, for example, if you get blue ear as a child, or you're more likely to have APD if, for example, you have specific language impairment. You can get that as you grow older, the same way you lose hearing, and so on. How do we make a diagnosis? We make a diagnosis with tests of hearing, but we need to ask the patient about their difficulties, because the difficulties are not on their own diagnostic, but they will help us choose the appropriate tests. And we also need, if we are to make a good diagnosis, to get information from speech and language assessments, assessments of intelligence, and occasionally other professional input. And there are guidelines for how to diagnose that. It's a combination of symptoms and a combination in abnormal findings in the tests. But we have to think various things before we make a diagnosis, because there is no diagnostic gold standard. So, for example, the age of the patient. We can't make a good diagnosis if somebody is younger than 7 years old because of the tests we have. Then the tests we use, are these good enough? There's a range of tests we can use, and not every test is appropriate. Sometimes we see conflicting results because somebody may not appropriately collaborate with us when we do the testing, and may give us results that are because, for example, he was not attentive enough. And then we need to put this information together with other assessments to make up our mind. So when we get children for this evaluation, they have to be older than 7 years, they have to have a normal IQ and a normal audiogram and significant listening concerns. And there is various criteria, listening or auditory complaints, and these are all the difficulties I mentioned to you in detail before. So what are we going to ask somebody to come to our clinic? We're going to ask, of course, what are the symptoms? Do you have problems listening in noise? Do you have problems if there are 2 speakers at once? When you're out and about and you hear a car approaching you, can you tell if it's left or right easily enough? Do you like music? When somebody talks to you and gives you a joke, can you get it's a joke? Things like that. Then we ask, what is the onset of symptoms? Always like that or more recent? We try to find risk factors from the history. We get history about other problems with health. We get history about early life development. Did you start having words, say first word, first birthday, at least 2 words together in a sentence by the time you were 2 years old, and so on? Educational history. Have you ever had problems at school? Why? Family history. Anybody like that in your family? Has there been any help for your symptoms before? What exactly is the situational context of your symptoms? And how do these impact on your life? And various other things. And then, after the history, we do a test battery. Again, that's a busy graph. But firstly, we do baseline tests. Then we do both speech and non-speech tests that assess auditory processing, and then we do additional assessments of language and cognition and so on. And here is a graph. Some of you may recognize that. It's an audiogram. So what this shows you is, for example, in this graph here, the top line gives you the different frequencies, and from here up to here are the speech frequency sounds, okay? You have to have good hearing in this range. While this one here gives you the intensity of the sound, how loud the sound is, from very soft to extremely loud. And then we get to the patient a sound, and when he tells us he can hear, and we find the softest he can hear, we plot the sign. So this patient here has got good hearing up to here, because it's around 20, but then it drops off, and down here he's got a hearing loss. We also have other tests, and if you had children, probably you've come across this test which is called the acoustic emissions. We do that now for neonatal hearing screening. So this is from a computer, and you see this one holds an ear probe. So you put that probe in the ear, this probe gives sound, and then the probe also records the ear's response to this sound. And this is the graph that we get. And for example here, you see this blue, the blue is the response of the inner ear. And you see it's a nice big blue response, and that's a nice normal response. So we want to see that, to say that your cochlea, your inner ear, is analyzing sound well enough. We do additional baseline tests, but then I'll take you through some of the central tests we do. And this test is something that kind of simulates how you are when two people speak to you at once. So this child here wears headphones, and one set of headphones gives a pair of numbers to one ear, 1, 2. The other gives another pair of digits, 5, 6, and they come together. So 1 comes together with 5, 2 with 6, and the child has to repeat all these numbers. And this gives us some idea about auditory attention and auditory memory as well as other things. And it's a good test, particularly for the population I'm going to talk about. Then there are some frequency and duration patterns. For example, you get beep, 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 and either you have to sing or to label that high, high, low, or beep, 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 long, long, short. Okay, and that again gives us information about various aspects of auditory processing. All this is the so-called gaps in noise test. So in this test you get a buzz, and inside that buzz there will be some stops or glitches. So you hear something like, and you have to press a button when you hear the stop or glitch. And this tells us how well you process fast sounds. But before I go on, again, this is a very scientific slide, but this is just to say that a big study was done on kids 6 to 11 years old. And they looked at auditory processing, and auditory processing actually explained poor performance with communication, poor performance with speech and noise, and also poor cognitive performance in some tests. And also what they found was that it was actually how the kids attended to these auditory tests and their cognitive scores that were the best predictors for how well they listened and how well they communicated. So what this is saying is that it's not just processing the sound, it's also attending to the sound that explains part of these difficulties. So, okay, you've got the patient, you've got the history, you did the tests, and you make up your mind that there's a problem there with auditory processing. So what do? What can you do? Well, when we think about how to manage somebody, we think about the test results and make a plan according to the deficits we find in the test, or according to the functional deficits. The patient tells us, oh, I've got this problem in a noisy room, so we have to find a way to help him with that. Or we can put things together and think about different combinations of symptoms and say, okay, this patient has got this profile, I need to do this and that and that. Usually we are test-driven or functionally driven. Okay, what do I mean by that? Well, for example, patients with problems, if there is a noisy room, if there is a room with poor acoustics, you have to modify the listening environment, okay? And you can make acoustic changes to the environment or do an FM system. For example, if I were to make this room better acoustically, I would put carpets, I would put heavy curtains, and I would probably use some acoustic paneling on the ceiling, because all this absorbs noise. If you've ever had your hearing tested in a biometric booth, if any of you has been there, you know as soon as you walk in the booth, it's so quiet. And that's because all these soft furnishings absorb sound. Schools are not very good listening environments. There are directives on how to make these appropriate now. But if you have an old school, chances is it's something like that, and there are corridors, and kids are running, and they're shouting, so it's a very noisy situation. So if you can't modify the listening environment, the next best thing is to have an FM system, although the advice given is you need both to modify the environment and give this system. This system, this shows you something that's a small hearing aid. So this bit goes into your ear canal, this hangs behind your ear and collects the sound. And the teacher wears this on his clothes, and this is a mic, okay? So the teacher talks to the mic, and the student gets the teacher's voice straight on to his ears. Very much similar to what happens in a good auditorium where somebody speaks on a microphone. But this comes straight to your ear. So this is a good way to bypass external sounds, and in many classrooms that's extremely helpful to kids who need it. Then you can do auditory training. Well, you can train yourself to play the piano, you can train your brain to listen better. And that's because the brain is plastic, so it changes. And there are various things you can do, and you have to start with something that's easy enough for the child to do, and then it gets progressively more difficult. And you have to make the child or the adult work at a level that he's not missing everything, because then you lose motivation. But also you're not doing everything extremely well, because what's the point of training if you're 100% correct? You have to make it more difficult. And learning is optimized when you work at the edge of competency, that's what we say. So what can you do? For example, these are easy things, low tech. And for example, we do some tests. And for example, we give a speech and noise test. I won't talk about filtered speech. Speech and noise, you understand. You get words in background noise. And the child has got problems. We say, well, this is a real problem in everyday life. The child is developing their vocabulary. So if we help the child to improve their vocabulary, they can guess the words more easily, even if the words are a little bit degraded because of noise. So we do vocabulary building, and that's something easy and cheap to do with the help of the mother and the teacher. If we do the dichotic digits test, if you remember the different pair of sounds to the two ears, and the child has got problems there, well, we may give an auditory vigilance task. For example, you read Harry Potter and ask the child to raise his hand whenever he hears the word Harry, or whenever he hears the sound ah, or something, whatever. If we get, for example, problems with the pitch pattern test, the beep, 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 we can get the child to read aloud and ask him to make his voice tuneful and ask him to listen to what he's saying. We get him questioned afterwards about what he's read. If the child has got problems with telling where a sound is, we can use things, ask him to detect sounds when we're out and about in the park and say, where is that sound coming from? And there are games like that. I think, do you know the Marco Polo game? Does anybody? Okay, so these are games that kids play that help them localize sounds better. So there are games as well. But there are computerized programs for both adults and kids. And I won't go through that, but I'll go straight on to the PAX6G. I haven't put an introduction here because I thought everybody would have this mutation and you know what it is about. But very briefly, it's a mutation that's rare. There are few people having this, but if you're born with Aniridia, and if you've got just one parent with this Aniridia, and we think this is dominantly inherited, which is 50% of chances of having this, if you've got one parent, then about 90% of cases will be due to this mutation, to this gene. So PAX6 is associated with congenital Aniridia. But not only that, this is a picture of the brain, okay? And this shows you, this is, say, the left and the right half of the brain, and this shows you this white tract here, which is very important, is the corpus callosum. And somewhere also you should see the anterior commissure up, and here is another small tract, the anterior commissure. So this tract connects the two parts of the brain. And this is a very useful connection because the brain works like a computer. The right bit is better, say, for music, the left bit is better for language. And you need to get information exchanged between the two halves of the brain to make sense of what you hear. Because my voice gives you, when I speak, you get word information from the left half that my voice is tuneful, and this tells you about what meaning I attach to what I say, and this is your right bit of the brain. And you need to put both together to make good sense of what I'm saying. And this is I'll show you this video. I'm not sure how many of you can see that. This is, you see how the green bit becomes less and less. Let me show you again. So this is starting from a very young child who matures, and then by the time they're about 21, there is very little green here. What this video means is that when we grow up, there are lots of connections in the brain. And the brain shuts down these connections because it's better for the brain to have specific parts to work on specific aspects of whatever, vision, hearing, sensation, and so on. This makes the brain more effective. And this process continues until you reach adulthood. And this process is probably underpinned by the interhemispheric pathway. In other words, this connecting pathway is very important because the brain is specialized, and this helps the brain work more effectively. And this interhemispheric pathway helps this process because it helps the two parts of the brain communicate. Okay. And very briefly to say that in 2003, there was a lady who came to me, and I looked at her auditory processing, and she had, when brain MRI was done, she had problems in the hemispheric pathway, and she also had problems with auditory processing. We then went on to test some adults who also have, if you see here, problems with the corpus callosum and the anterior commissure, so this is the hemispheric pathway. And these were the tests that we've done for auditory processing, and the grey bits show you the different abnormalities. So these adults did have problems with auditory processing, which were consistent with the abnormalities in these two parts of the brain. So we then wanted to look at children, and we looked at 11 children aged 7 to 17 years. And we repeated the same tests, and the brain scan, and the questionnaire. And again, A stands for abnormal. So again, there were various problems in the brain MRI, but they also had the same abnormalities that we had seen in adults in the same tests of auditory processing that I described to you before, the digits, the pitch pattern, and so on. These were the scans of some kids, which were very interesting. For example, this one shows you that this bit here should be bigger. See, for example, this is normal. So this, see how smaller this is than this one, okay? And that's where the hearing fibers go through the corpus callosum. Or this one, you see it's small. Well, this depends also on the age of the child, so it might not be always obvious. And there is a cyst here, which there shouldn't be, so there were various problems there. But what was interesting, I also did a questionnaire and compared it to kids of the same age. So the parents reported that their kids had problems understanding speech in noise and telling where a sound is coming from. And that's something that we thought made sense in view of the test, and also in view of, well, the kids don't have so many visual abnormalities at that stage of life. So it's probably most likely to be due to the auditory processing. Okay, so I'll just take you through a case study, because that was a child who was 11 when we saw him. Probably ignore this picture, but it just tells you that he had several problems with the test that we did in auditory processing. And just to say that we did a language assessment, and he was great in many aspects. In fact, he was a very clever child and he was top of his class, but he had problems with his auditory working memory, retaining in memory recent information. So we gave him an FM system in the classroom because he had problems in the class. For example, when he came to me, he said, the teacher asked, are there pigs in the sky? And I hear, are there pigs in the sky? And so I say yes. And then everybody laughs at me and, you know, mortified. So we gave him an FM system, and initially he was very pleased. This made his life much easier, but then he became a teenager and he was not happy to have an additional thing to make him different from the other kids. And we also did some auditory games, training and so on. We liaised with his school and described his difficulties and health. And after we've done the language assessment, we gave him various other pieces of advice, like recording information in pictures, mnemonic devices, use of a diary, various planning skills, and so on. So that was all I had to say. So just to say that it's not, auditory processing disorders is not unusual in the general population. If you've got congenital aniridia due to a PAX6 mutation, it's even much more likely to have that. This can result in listening difficulties, in challenging listening environments, and there are various things we can do, particularly if you're at school, or even when you're an adult, we can give advice about the professional environment. It's still an area that's under development, but I find this an interesting area, and that's all I had to say. Thank you very much for your attention. Are there any questions or comments? Yes, lots.
My daughter's got WHL.
Yes,
yes. Syndrome, and so does Susan's. So this is a big area for us. Well, for me, Ella's 4, Clara's 2, but Ella's just about to go to school. And I'm battling at the moment with my audiology team because they just want to put hearing aids in. And I'm trying to explain to them that if she can sit in a room and hear the music through another room and another door and beat this rhythm music out, she's not deaf, but she can't always process. She's got delayed speech, her phonetics are all mixed up.
Yes.
Right. I won't take APD seriously. I can't make them take it seriously.
How old is she?
She's 4.
Okay, that's a difficult area. What's your area?
Northumberland.
Northampton.
Northumberland.
Oh, right, yes.
Okay, gosh.
Near Newcastle.
Yeah, but we come to go on the street to seek clinician for her eyes.
Well, why don't you come to see me as well?
Yeah, I was going to say,
Look, she's 4-year-old, so what we need first is to do, she won't be ready to do this test, but what we'll be ready to do is a really good assessment of her hearing, that she hears some sounds and see that. So ask Ken Michal to send me referral. I may book here in a different consultant's clinic to speak things up and explain exactly what is needed, and I can come on that day and see her as well, just to make sure that she comes quickly.
Because
Okay?
I'm a bit nervous about them doing it, and I have talked a lot about it, and they don't really believe in APD. And I've said to them, you don't understand. I know this is very much happening with Ella. So even if you could, because we've got to go back to another hearing test, but the hearing test is hilarious because she's stimulated visually, so she's not concentrating auditory. Then they're trying to get into some stuff tactile, so she can't hear, see or touch well, because all three senses are being set off at the same time, and I might have got to separate it. So they just don't
They're not very much aware.
We're due to come, I think, around the 26th of May. So if I give you my contact details, I'll take.
Well, I'm not sure that, I think 26th of May, is that the Thursday?
If not, we'll come
No,
down.
what I would say is I need a referral. Either from your GP or from Ken Michal, whichever.
Well, if I email him and then CC you in.
Yeah, that's great. You can make a referral and then I can make sure that she's booked in a clinic because she needs a good, basic assessment of hearing to start with. Okay, sure.
Is there any chance that all our children with aniridia could be monitored for this if it's so closely linked and the chances are higher? Is there any way that, because we tend to, as soon as you've got aniridia, they do think about Waltz tumour. That seems to be quite a good monitoring link. But we certainly haven't.
I certainly say that because when I look back at the graph of the kids, okay, these were 11 kids, okay, so if you see, there was just one who was completely normal in all tests. So yes, it's quite likely. So what I would say is once they're 7 years old, it would not be a bad idea to get this assessment. And here we're running problems because at the moment at the United Kingdom or abroad for that matter, there are very few clinics that can offer this assessment. If you're happy to come to London, it's not difficult if the child is 7 to do this assessment either on the NHS or even as research for whatever reason and make some recommendations. If you're outside London, there are few centres. I think they do this testing in Manchester. They do this testing in 2 places south of London, in Wales. But that's about it really.
Would you be able to send me a list of perhaps the centres where they do tests?
Yes,
so
I can.
If people ask, we can tell them.
I can send you the list. But what I would say, if you feel that there are any listening difficulties of the child or problems with education, press strongly for a referral, even if the centre is not very local, just so you get a good baseline and some help. Because
who do we press the referral from? Who do we press for the referral from through the?
It's the general practitioner, but the child is statemented as well, isn't it? The child is statemented. So this will give some additional information to the educational environment, because the problem is that the assumption is that if there are problems with vision, then we rely a lot on hearing. When the hearing has got a few problems as well, things are made more difficult and one has to understand. And unfortunately, we don't get intuitively what the problem is. As you can see, I said I'm not visually impaired aware. I'm hearing impaired aware, but not visually impaired aware. I apologize.
Just as a quick, do all aniridics get segmented?
Not necessarily.
No.
It should be.
Yeah, I mean, it does depend on individual cases. So, but you would
Do
say.
you have to be statemented?
No, you don't. If there are any listening concerns for this child, if the child is not doing well at school and there aren't any obvious reasons for this, it's worthwhile having this assessment.
Would you say that a majority of people with PAX6 mutations have APD?
Okay, that's a different, let me say one thing. Test results don't always mean you have problems in real life, okay? So we find the test abnormalities. How many people of these have the problems actually in real life? And because I know these kids, this one with the normal tests was absolutely fine, no problems at school. Then Chris here did have some problems, but was very clever and was, you know, sailing. You know, he was really great. There was another child here coming from America who didn't have a scan, who came to see me explicitly to have the test as part of the research project. And then I think this child here was coming from Malta with problems. So from this, you know, at least about half of the kids had very significant problems. And I think...
I know that the Norwegian Aniridia group said, their president said to me that they felt, I mean, they hadn't, their opinion amongst the parents was that almost 50% of the children in their group could have auditory processing.
Well, that's my, you know, that's my clinical opinion. You see, you know, when we communicate, we rely on a lot of information. Hearing, vision, how well we get language, how clever we are, how attentive we are. So it's a combination of things. So whether somebody will experience problems might well be because of every other resource. Having said that, if you really try to compensate for something and you stress your attention because you can't hear very well, at the end of the session you'll be so tired. And that's something that the parents of my kids tell me. Once they get the FM system, boy, they come back from school and they're not as tired as they used to be. So, you know, I'm not somebody who's evangelical saying, okay, everybody will have the problem. Some people may have the test deficits but will not experience a great deal of difficulties. But some will do, particularly kids who develop language.
And just thinking, because, sorry, going back to Anna at the moment, she's having a lot of periods throughout her day where she has what we call meltdowns. I think she's overtired visually, and I think she's auditory exhausted. She's exhausted with the stimulus.
I guess, you know, the problem is not just tiredness, it's also that the child is developing a perception of herself during this time.
Yeah.
And,
but
you know,
she's not verbal, so she
yeah.
can't.
So it's difficult, and
but I think she's very aware that I think she's actually aware that she can't take it in this way. Yeah. She can't take it, but then there are certain times when all the settings are perfect and they're very small. You know, she can hear very well, she can see very well. But then there's a lot of the time when that's all mixed up, and it's causing her a lot of stress.
A very structured kind of
and I need this
environment.
advice from her teachers, because how can they teach her if she's not got the right environment?
No,
she won't learn.
Ask them to send a referral. I would like that.
When I was young, I suffered from blue ear and I was classified as being dyslexic. But later on in life, I was retested and I was told that I wasn't dyslexic, I had dyslexic tendencies, but the main thing was I wasn't hearing words properly.
Yeah. So that might well be another risk factor.
Basically, I was being pigeonholed as being dyslexic when I wasn't.
Yeah.
And I have great problems in a noisy environment, sniffing out the sound. Can we ask our GPs for referrals?
I see adults at the National Hospital for Neurology. I'll be delighted to see you there. Yes, you can ask your GP. You've got my contact details. Katie has got my email and name and address. If you know, any referrals are sent there, and
I'm interested, particularly with this gentleman talking about dyslexia. How do you differentiate between a learning difficulty, which is, you know, hindering connections in the brain between the actual audio perception?
Well, dyslexia is a different matter. It's a reading disorder. Okay?
Yeah, no, I appreciate
so
that, but there are things.
You can have dyslexia with or without auditory processing disorder. The diagnosis of the auditory processing disorder will be on the basis of this hearing test, dyslexia on the basis of the reading test. Some patients with dyslexia will have APD as well, okay? Or some patients with APD will have dyslexia, because they're not uncommon in the general population. But what this gentleman said might well be that he was misclassified. He did not get proper access to sound to develop reading well enough at that point in time, and people thought that this was dyslexia, while it was probably not having good access to sound and not processing sound well enough after that.
Well, I think the initial problem was the fact that not only just having a vision impairment, I was suffering from glue ear until I was about 11.
Yeah,
So
that's a long time.
Yeah.
Yeah. Yeah, no, this is not unusual, and this is not an unusual scenario.
A lot of children with WAGA obviously have the Aniridia, not all of them, but most of them, but they also have the added difficulty of some degree of learning difficulties. How easy is this to diagnose with children?
That's tougher, to be honest, because current referral criteria specify you need a normal IQ. The reason for that is that when we look at the test results, we compare them to kids with normal IQ of that age.
Yeah.
So if a child has got a learning difficulty, it's more difficult to say what's happening. In these cases, I usually try to see, can the developmental pediatrician tell me roughly what is the developmental age of the child?
Right.
If I do the test, are the results roughly at that developmental age? And then I can make up my mind if it's more auditory or if it's more learning related.
So you're really waiting for them to get to a developmental age of 7?
Well, yes.
Yeah.
Because these tests require a lot of, you need to remember things, you need to differentiate between long, short, high, low, so they're not very easy. But, you can do various modifications.
Yeah, because when Tara had an MRI brain scan, they said that everything seemed to be there, but it was smaller than, her brain was smaller than normal, which I think is quite common from having read your research and what have you.
Yeah.
So is it worth sort of asking for another brain scan to look at these particular sort of corpus callosum and anterior
Usually when they do a brain scan, they do, particularly if there are learning problems. The corpus callosum is a prime suspect. So a good radiologist looks at that.
Yes.
As long as the radiologist who did that had experience with pediatric scans, this is something that usually does not go amiss.
Yeah.
So no, you don't need an additional scan. They would all look at.
So because I think she was scanned at something like 7 months or something. So would you be able to tell at that age?
To be honest, I don't know. You see, that's the other question, whether there are developmental changes throughout life. For PAX6, I don't know about WAGA. I'd say, how old is the child now?
She's 2.
She's still young.
Yeah.
Leave it a bit for, see how she develops. If there are any problems with her acquiring language and so on,
Yeah.
get them to be addressed by speech and language people and leave it a bit, because you don't need to scan her again in such a short time.
Yeah. What age do you think we should be referred to an audiologist?
Do you have any listening concerns? That should be speech therapy.
Localizing sound, I think she does have an issue with that.
That should be speech therapy.
Yes.
Usually discuss this with the speech therapist if she thinks there is any significant problem with hearing. If the speech therapist thinks there is, then get her referred.
Yeah.
Usually the speech therapist will pick up on this. Not always, but in most cases, particularly with kids.